Hello everyone, welcome to JRM Pediatrics. Today we shall be learning about two important genomic imprinting disorders, that is Prader Willi syndrome and Angelmann syndrome. Let's start with Prader Willi syndrome. It is characterized by severe neonatal hypotonia and feeding difficulty. But later on, as the child grows, it becomes excessive weight gain, which starts around 12 to 18 months of age, and hypogonadotropic hypogonadism. Now, here the maternal imprinting is present. The syndrome develops when there is paternal chromosome 15q11q13 deletion. This is the most common scenario in 70% of the cases. Next, if there is maternal uniparental disomy in 30% of the cases, and abnormal methylation of imprinting gene, which is rarely seen. Hence, in case of Prader Willi, P for paternal chromosome deletion. Now let's come to other signs and symptoms. We see hyperphagia here, and there is absence of satiety. As the child grows, this worsens. Short stature due to growth hormone deficiency, genital hypoplasia, infertility, incomplete pubertal development, cryptorchidism, hypothyroidism, obstructive sleep apnea, scoliosis, diabetes mellitus, which is usually unresponsive to oral glycemic agents. Learning disabilities. Now coming to the faces, there is a narrow forehead, almond-shaped eyes, thin upper lip, downturned mouth, and short hands and feet. These children usually have temper tantrums when they start school. Now how to diagnose? DNA methylation testing is needed to detect the abnormal parent-specific imprinting. For uniparental disomy, we need to do a FISH or microarray. The treatment encompasses growth monitoring, growth hormone therapy, calcium and vitamin D supplementation, thyroxine, antipsychotics, diabetes mellitus management, speech and language therapy. Now here, obesity is one of the biggest risk factor to predict the prognosis of the syndrome. In Prader Willi, the death is due to Beckwith syndrome, which is a triad of obesity, obstructive sleep disorder, apnea or sleep disordered breathing, chronic hypercapnia during wakefulness. Now let's go on to Angelmann syndrome. In Angelmann syndrome, normally the paternal imprinting is present. The defect arises when there is maternal deletion of chromosome 15q11 in 70% of the cases. Angelmann has a M and maternal deletion. Prader Willi had a P and paternal deletion. Here there is a mutation in UBE3 gene on the maternal allele which can result in this syndrome. There can be paternal uniparental disomy and methylation defects again rarely. This mutation in UBE3 gene is inherited from proband's mother, hence there is a recurrence risk of 50%. The clinical features are seizures, they are prone to Salam spells. The EEG shows high amplitude slow wave cycle of 4 to 6 Hz per second. Paroxysm of laughter, they are known as happy puppets as you can see here. There is severe mental retardation. Now in Prader Willi, there can be learning difficulties, but the mental retardation aspect is more severe in case of Angelmann syndrome. There is ataxia, jerky movements, puppet-like gait, hypopigmentation, microbrachycephaly, tongue protrusion, wide mouth, fair hair and blue eyes. Now there are few other genomic imprinting disorders as well. The most two important ones that we need to remember is Russel syndrome and Beckwith Weidmann syndrome. Even in case of neonatal transient neonatal diabetes mellitus, we can see genomic imprint is a part of the genomic imprinting disorder. That's it for this class. Thank you.